with that, we move on to our last speaker. This is Professor Zhang from the General Hospital of the Chinese People's Liberation Army in Beijing, China. And she will talk about the potential of contrast-enhanced ultrasound in breast cancer. Dr. Zhang?
Hello, everyone. I'm Zhang Yan. I come from the Chinese PLA General Hospital. My title is Contrast-Enhanced Ultrasound in the Diagnosis of Breast Cancer. To our knowledge, in the worldwide, the incidence and mortality of breast cancer rank first among female malignant tumor, so it has attracted people's great attention. There are many methods of breast imaging examinations, among which ultrasound is the commonly used screening method in China. For most of the breast nodules, ultrasound can get accurate results. However, there are often overlaps between benign and malignant lesions, which leads to the misdiagnosis and misdiagnosis. Angiogenesis is very important for the tumor growth and proliferation. The anatomical structure and distribution of microvessels in carcinoma are different from the benign nodules. CEUS, that is contrast-enhanced ultrasound, can observe tumor microcirculation by using contrast agents, so it can be used to differentiate the malignant tumors from benign. And CEUS breast lesions are differentiated by analyzing qualitative characteristics and measuring quantitative parameters. So, some important parameters are shown in this table. As the picture shows, the direction of perfusion, peak intestine, enhancement shape, margin, and area are different in benign and malignant tumors. These pictures were from different types of benign lesions. They usually showed clear margins, no enhancement, hypo-enhancement, or homogeneous centrifugal enhancement of the lesion, and dendritic branching vessels. In contrast, these carcinomas showed blunt margins, heterogeneous centripetal enhancement with perfusion defects and distorted vessels. Malignant lesions have significantly shorter time to peak, high peak intestine, and increased wash-in slope. In recent years, the application of CEUS in breast is written in the international guidelines. More and more research results confirm the value of contrast-enhanced ultrasound in the diagnosis of breast lesions. The breast contrast-enhanced ultrasound can predict the risk of malignant lesions more accurately, decrease false positive biopsy, and provide accurate by-race classification. Some characteristics could predict the tumor's histological grade, lymph node metastasis, and biomarkers. There's a good agreement between the US in combination with the contrast-enhanced ultrasound and MRI in the differentiation of benign from malignant lesions. Now let me share some cases. This is a hypoechoic nodule with ill-defined margin and irregular shape. In elastography showed it was stiffness. So this nodule was reported as the BIRADS 4A. However, this nodule was non-enhancement all the time during the contrast-enhanced ultrasound examination. So it was downgraded to 3. Then it was treated with minimally invasive vacuum, and the pathology is benign. This is the lesion, just like a cyst. This is a lesion with irregular shape and rich blood flow supply. It was reported as Barrett's 5 by MRI and Barrett's 4B by conventional ultrasound. And the elastography didn't provide useful help for the diagnosis. During the CEUS, the lesion showed internal hyper-enhancement, and the perfusion was fast wash in and fast wash out. In addition, we observe a duct-like structure, which shows low or no enhancement near to this lesion. So we consider it may be a lesion originated from the duct, and the pathology is intraductal papilloma. This female patient with solid ankle detected by CEUS in the right mammary duct for 2 years. Ultrasound reported Barrett's 4A. But no enhancement was observed in the duct during the CEUS, so it was downgraded to Barrett's 3. Then we injected the thalate into her dilated breast duct, and then some sticky stuff was washed out of the nipple. After that, biopsy was performed, and the pathology is duct dilation with epithelial cell proliferation. This is a woman in breastfeeding period, and palpable lump was found, and this lesion showed hyper-echo area in the sonogram. Focal region showed the steep by elastography. It was reported as the Barrett's 4B. And the CEUS, this area displayed obvious and lasting hyper-enhancement feature, so it was upgraded from 4B to 4C. And the surgical pathology was invasive ductal carcinoma. The status of axillary lymph node is very important assessment content for the breast cancer patients because it was related to the surgical strategy. Sentinel lymph node, that is SLE, is the first station of the tumor metastasis. Enter breast, more than 75% lymphatic drainage to axillary. And there are 3 groups of lymph nodes in the axillary. In clinic, there are radioisotope and dye methods mark the SLE, but they have some obvious disadvantages such as the intraoperative application, but not the preoperative diagnosis, allergies and radiation, and so on. Lymphatic CEUS is a new modality. Contrast agent is injected subcutaneous in the areola to reflect the perfusion of sentinel lymph node. Studies show that in the early stage breast cancer, preoperative localization of the sentinel lymph node by CEUS improves the accuracy of the biopsy, and the accuracy was higher than the blue dye guide biopsy. In the normal condition, lymphatic duct and lymph node can be displayed clearly, and the lymph node showed homogeneous enhancement. However, for the metastasis, the sentinel lymph node will show heterogeneous enhancement. For example, this one displayed irregular ring enhancement, and these two were showed enhancement with obvious perfusion defects. And the last one was non-enhancement because the lymphatic vessels were filled with cancerous plaques. CEUS can detect the abnormal sentinel lymph node, which showed negative on sonogram. For example, this patient had breast cancer, but the axillary lymph nodes were normal, showed by ultrasound. During the CEUS examination, a very small perfusion defect area was found in the sentinel lymph node. So it was diagnosed metastasis, and the surgical results showed only one sentinel lymph node is metastatic. This is a woman with very small breast cancer, and also no obvious abnormal axillary lymph node was detected by the conventional ultrasound. Contrast enhanced ultrasound showed sentinel lymph node is heterogeneous enhancement, and then guided the biopsy. The pathology showed and was metastatic 1. The surgical results also confirmed that showed only one was the metastatic sentinel lymph node. Although CEUS is effective in most patients, but there are also some false positive existed in some patients. For example, these two patients with breast cancer showed heterogeneous enhancement sentinel lymph node during the CEUS examination, but their final surgical pathology results showed that no lymph node metastasis. So in general, the reasons of false positive including as follows: lymphoid follicle hyperplasia and lymphatic sinus dilatation, lymph node reactive hyperplasia, adipose tissue deposition, fibrotic and lymphoid tissue deposition, lymphatic vessels with cancerous plaques. So in summary, contrast-enhanced ultrasound is a high-performance, feasible, non-irradiating method and has proved to be a valuable addition to breast ultrasound. Thank you very much.
Thank you so much for this very interesting talk, and again highlighting another aspect of the use of contrast-enhanced ultrasound. I'd like to invite the audience again to send in questions they might have. And for the time being, I'd like to ask you about the amount of contrast you are applying for the evaluation of nodules, and then also for the detection of sentinel nodules.
We do the sentinel lymph node, the CEUS, for the early stage of breast cancer. So maybe we didn't commonly use this method for all patients. Thank you.
And how much contrast do you apply? How much milliliters? How many milliliters?
Under the contrast enhanced ultrasound for the axillary lymph node, we use one milliliter. And for the breast cancer, we may use 3.5 ml to 5.
Okay.
Thank you.
Thank you so much.
Thank you.
And so you mentioned the indication already. So you are focusing here primarily, I think, in younger patients. And how many patients do you evaluate using contrast, just to give us an idea on how routinely you're using this method in your daily life?
I beg your pardon. Your question is for the axillary sentinel lymph node.
No, this was more on the indication, because I got this question also from the audience. What are the indications for contrast-enhanced ultrasound for the evaluation of breast lesions? So when do you use contrast-enhanced ultrasound?
CEUS is used for the patient with lesions difficult to diagnose by the conventional ultrasound. That's all.
And do you use it then in all cases, or just cases which? So my question is, when do you send to MR, and when do you go directly to contrast-enhanced ultrasound?
Just I asked the question. We use the CEUS for the patients difficult to diagnose, and the nodules cannot diagnosis by other imaging such as MRI or yes, mammography.
Okay, so no strict criteria, it's just an individual decision as far as I get it now. Okay, did you have any false positives, and how do you deal with them?
Yes, I think CEUS is not 100% for all patients, and the false positive exist both in the breast cancer and breast nodules and the axillary lymph node.
Okay.
Yes.
Okay, I don't see any more questions from the audience. So if there are no more questions, I'd like to thank all of you. I'd like to thank the presenters for sharing their knowledge and for sharing their experience with contrast-enhanced ultrasound in these very interesting topics outside the liver and standard use of contrast-enhanced ultrasound. And I'd like to thank also all of the audience to be here with us. I see from the list that this is a spectrum of countries where people are joining today. So once again, thank you very much. And I hope to see you in the near future in another EFSUM webinar. And again, I'd like to thank Braco for supporting that and supporting EFSUM in this endeavor. Thank you, sir. Thank you very much.
Thank you very much, Chairman.
Thank you very much.
Thank you very much.